From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm your host, Dr. Karen Lasser, Professor of Medicine at Boston University and Senior Editor at JAMA. Today, I am joined by Dr. Elliot Tapper, who is an Associate Professor of Medicine in the Division of Gastroenterology at the University of Michigan. Welcome, Dr. Tapper, to this JAMA podcast.
A privilege to join you, Dr. Lasser.
So, to begin with, your review covers the diagnosis and management of cirrhosis and its complications. Can you tell us how common is cirrhosis, what are the main causes, and how have these changed in recent years?
A very good question. So cirrhosis broadly affects just over about 2 million Americans. Now, a precise estimate largely escapes us, but this is the best data that we have. And what we do know is that people with cirrhosis tend to be overrepresented in our hospitals owing to the severity of their complications. So it definitely feels more common than it is. Now, today, the most common causes of cirrhosis are non-alcoholic fatty liver disease, which is typically associated with the metabolic syndrome, and alcohol-related liver disease. Hepatitis C used to be one of the most common causes, and it is still a common cause. But because we are screening for it, and because it is so easily cured, it will be less represented over time.
And how helpful is the history and physical exam in diagnosing cirrhosis? Are there any signs or symptoms that are particularly sensitive or specific for making the diagnosis?
Cirrhosis comes with a lot of classic physical exam findings. Things like spider angiomas on the face or neck, palmar erythema, caput medusa, dilated veins on the abdominal wall. And these things tend to be pretty specific for advanced cirrhosis, but they're not very sensitive. And so one of the key things that we wanted to get across is that for the vast majority of people with cirrhosis, they may not know it because it has a very long latent period that is asymptomatic, and additional tests, both blood-based and imaging-based, are required to learn if a patient at risk for or with a known liver disease has cirrhosis.
Which patients should we evaluate for cirrhosis, and is a liver biopsy needed to make the diagnosis?
I think at this point, we want to evaluate people with known strong risk factors for liver disease for the presence of cirrhosis. So at a minimum, if you've identified somebody with viral hepatitis, hepatitis C, hepatitis B, that's someone where we want to know if they have cirrhosis. If you found fatty liver by way of an ultrasound or CT scan ordered for another reason, or if your patient has diabetes and has a very high body mass index, these are things that should raise the possibility of a liver disease that could cause cirrhosis. And of course, if they have long-standing alcohol use disorder. And biopsy, it will definitely tell you if your patient has cirrhosis or not. But fortunately for us and for patients, there are a variety of alternatives that have proliferated in service of that diagnosis. In short, I'll just say there are blood-based indices, and the most popular one is called the fibrosis-4, which is based on the ratio to ALT and AST, where the higher the AST, the more likely someone has cirrhosis, and the lower the platelet count, the more likely they have cirrhosis. And anybody can calculate this. And then beyond that, we use an imaging-based test called elastography, which can be provided at the point of care using a method called vibration-controlled transient elastography, branded as FibroScan, or through other imaging apparatus like magnetic resonance elastography or shear wave elastography, which is accompanied in many ultrasound platforms.
Now, once we've diagnosed cirrhosis, how can we improve survival among patients with compensated cirrhosis? For example, how should primary care physicians screen for complications such as varices and hepatocellular carcinoma?
So, this is the critical question, and one of the most important takeaways of our work is to share a lot of optimism that we can improve survival and the ability for our patients to thrive after a diagnosis of cirrhosis. So, at a minimum, you should know that if you control the underlying liver disease, the fatty liver disease, the viral hepatitis, the alcohol use disorder, these things will be associated with prolonged stability and maybe even reversal of cirrhosis. And then beyond that, if a patient has cirrhosis, we recommend that they undergo screening for liver cancer every 6 months with a modality like ultrasound and alpha fetoprotein. And this is associated with increased early detection and therefore the possibility of cure for liver cancer. And you ask about varices, and this is important for two reasons. One is that typically we will screen for varices every 1 to 3 years based on the comorbidities or severity of the liver disease. And we'll do that with endoscopy. And if we find varices, we will initiate therapy like a non-selective beta blocker. And that will prevent variceal bleeding. But increasingly, we're learning that people with compensated cirrhosis who have small varices or portal hypertension, i.e. the pressure in their portal vein has increased over 10 millimeters of mercury. If you start them on that beta blocker, not only will they be less likely to develop variceal bleeding, but they're less likely to develop ascites and therefore less likely to die.
Now, you may have covered a little of this already, but can you talk about the prognosis of patients with cirrhosis and how can we know when to start thinking about the need for a liver transplant?
So, the vast majority of people with cirrhosis will be diagnosed either early because you went looking for it or because it was incidentally detected by lab tests or imaging. And these people have compensated cirrhosis. And the median survival for patients with this stage, where it's clinically silent, there's no ascites, no encephalopathy, the median survival is about 12 years, but it has a pretty long range depending on the age at which it's diagnosed. That's important to know. But once you develop a decompensation, like ascites or variceal bleeding or hepatic encephalopathy, the tool that we really use to determine prognosis, that's the MELD score, MELD, and it's based on the bilirubin, the INR, the creatinine, and the sodium. And it gives you a sense of the probability of mortality at 90 days. And this is super helpful when someone has these decompensations. And when that score is higher, then they should definitely be referred for a liver transplant. So typically, we want to see in our transplant clinics, as opposed to our general hepatology clinics, people who have decompensations, hepatic encephalopathy, ascites, or a MELD score that's approaching 15 or greater. And the range for MELD scores is like 6 to 40.
And what are some common symptoms of cirrhosis, and what are the evidence-based treatments for them?
So, a lot of people are familiar with the canonical decompensations or symptoms of cirrhosis, like the ascites and abdominal bloating, the hepatic encephalopathy, the asterixis, the confusion, disorientation. But it turns out that if you ask patients with cirrhosis what's really bothering them, it's a set of symptoms that is both very common and independently associated with poor quality of life. And these include muscle cramps, which is directly related to the pathophysiology of cirrhosis. It happens predominantly in the lower body, but sometimes can be their hands or abdomen. Itching, because the liver is causing a backup of bile salts into the blood, which irritate the skin. And beyond that, these factors will also result in sleep dysfunction. And because cirrhosis disrupts many of the common endocrine systems, it will also cause sexual dysfunction for both men and for women. Now, the treatments for these are many, and we review them, but I'll highlight a couple. For muscle cramps, the things that are best tested are a sip of pickle juice, which, interestingly enough, triggers a nerve reflex that will abort the cramp, but it does not prevent the cramp. And so a studied drug is taurine, taken at about 1,000 milligrams twice per day. For itching, many of us will use bile acid binders because of the pathophysiology of the condition, like cholestyramine or cholestyramine. And sometimes we will go to second-line therapies like naltrexone, which mediate the sensation of itch. For sleep dysfunction, we really try to focus on sleep hygiene, but when we need to reach for another agent, things that have been trialed include hydroxyzine at night and sometimes melatonin. And when it comes to sexual dysfunction, the same things that would treat this condition in any other patient also apply. But it reminds us about two main things. One is that alcohol use disorder is associated with sexual dysfunction, and sexual function can return spontaneously with cessation of alcohol. And there are a variety of prescription therapies for erectile dysfunction that are safe and effective in cirrhosis.
And once patients develop complications of cirrhosis, are there other evidence-based treatments that they should receive?
Yes, each of these complications has a wealth of data behind it, and I will briefly summarize. For people with hepatic encephalopathy, this is a condition that is associated with frequent hospitalizations, falls, and trauma. And I think a lot of us know about lactulose, but what you may not know is that lactulose, when consistently applied in the randomized trial setting, is associated with improved survival. And when someone has breakthrough episodes on lactulose, rifaximin is approved by the FDA and is associated with improved freedom from repeated episodes of encephalopathy. When it comes to ascites, we have a variety of now older clinical trials which have established that the optimal therapy is a combination of aldosterone antagonists like spironolactone and loop diuretics, which largely function by protecting the patient from hyperkalemia. And these therapies will help resolve the ascites, but when they don't, there is paracentesis that's available in a pinch to help the patient with relief, but it will not solve the problem. And for people who are requiring multiple paracentesis, we will consider transjugular intrahepatic portosystemic shunts, or TIPS. And these procedures can be incredibly effective for patients with ascites refractory to diuretics. Now, for variceal bleeding, the best therapy is non-selective beta blockers to prevent them in the first place. And the most preferred one at this point is carvedilol, which is hepatically metabolized and therefore dosed once per day at a dose of around 12.5 milligrams ideally. But if someone has had a variceal bleed, that ought to be accompanied by serial endoscopies to place bands on any existing varices to make sure that they are completely obliterated.
So which agent should be used to prevent variceal bleeding?
Thank you for that clarifying question. Now, I did mention carvedilol, but the truth is that for people who respond to propranolol, either agent is preferred. So propranolol is typically a medication which is dosed twice daily, and we know that it is effective typically in people who achieve a heart rate on therapy of around 50 to 55 beats per minute.
Were there any final clinical pearls that you would like to share with our listeners?
The privilege of getting the chance to talk about cirrhosis in a journal like JAMA is to make sure that people know about the scope of the problem as it affects American public health, our ability to diagnose it at an early stage, and to infuse optimism with the idea that there have been multiple established, proven therapies that not only help our patients feel better, but live longer.
Terrific. I'm Dr. Karen Lasser. I've been speaking today with Dr. Elliot Tapper from the University of Michigan about the diagnosis and management of cirrhosis and its complications. This episode was produced by Shelley Stephens at the JAMA Network. The audio team here also includes Audrey Foreman, Mary Lynn Ferkaluk, Lisa Hardin, Daniel Morrow, Daniel Musisi, and Hannah Park. Dr. Linda Brubaker is the senior editor for JAMA Multimedia. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.